This is mine.
It's your own one.
This is, yeah.
Right.
I like using it. And that's a good, how about that? Who's had hard splints here? And who would say, oh, I like using it? Not too many. These things are really cool. They're soft, spongy.
So is that made by a dentist or?
Yes. We get, these are hand guard, made by my friend. Yeah, it's really good friend of And I modify them because we don't want it too bulky at the front, so the lips will come over it. And we just mould it right there and then.
So you think the soft ones are better?
I know soft ones are better, but that's me. Yeah, I do. And I'll tell you why. If the literature shows that if you really follow up people with hard splints, and the literature is really poor at doing that, and we were discussing that earlier, about 40% at least don't modify muscle activity at night, which equals not getting better. So the key is muscle activity while sleeping. This little baby, when the person clenches, the brain goes, whoa, it's all spongy. There's no payoff. There's no perverse delight in clenching because you're on this spongy surface. You are keeping the teeth apart, which a hard splint does as well. But what it really does, it allows the lower jaw to go wherever it wants while asleep. It disengages, because most hard splints have a dedicated occlusal position. And that occlusal position is taken when the person's sitting up or lying back a bit. Guess what happens when you lie down? It's different. So, I mean, really and truly, this system is fluid, plastic, mouldable, adaptive. It wants to go wherever it wants. The major factor for us as therapists is to get the muscles happy. And if the muscles are happy, pretty much everything else falls into place. And it's a powerful, simple, easy peasy, quick thing. Hard splints are complex, pretty costly, frustrating because not everybody gets better. Would you agree? I would say so. I've made them. And that's why I was making them with Peter Lestrange at the dental school when I was studying oral surgery, because I was interested at that time. I had a click myself. I'd annoy everybody in the academic staff room by my jaw going click, click, click when I'm eating my hamburgers. Click, and they're all looking at me. And it started to get sore. I was interested in how, but I knew we were missing stuff in the overall management. Peter was an occlusionist and splints were his thing. And they did work for some. I'm not sure that the patients really liked them and would go back to wearing them whenever they're stressed. Maybe they would. But in some people, they didn't work because it didn't modify muscle activity long term. It did initially, and then the person would overcome the splint and it'd go back to pre-treatment levels. It didn't get better. So yeah, I love those because they're easy and effective and low cost. Seems like a lay-down misère.
Do they prevent dental damage from growing?
Yes, you can my dental colleagues over there will love this. If you've got a dodgy tooth, cracked, undergoing root treatment, whatever, for heaven's sake, protect it with that during the vulnerable phase, because vulnerable teeth often rise up in their sockets a little bit. The person unconsciously grinds on them a bit. It's all bad. You've got to rest the tooth or grind it out of occlusion. But rest the tooth rest the teeth.